Hi, this is Elliot Fishman, and welcome to the October 25 quiz. We have 10 excellent cases, so let's get started. The study protocol used on this dual energy case is for evaluation of, well, that's classic. This is for gout. We don't have really good techniques for rheumatoid arthritis or Paget's disease. There is some software with AI. You can measure the presence of osteoporosis, but this is a classic example of using dual energy for gout. A really nice example. In this patient on dialysis for end-stage renal disease, the best diagnosis is, well, what do I see here? I have two images which show the patient has a AV fistula for the patient's dialysis, and you see multiple lobulations of the graft. This is an unusual case of AV fistula created, but now has multiple saccular aneurysms. This is not the normal look of the bypass. It's not a vasculitis, and it's not an infectious vascular disease. It's multiple aneurysms. One of the common complications of AV fistulas over time is developing of aneurysms, but usually they're more focal. I've not seen one looking at the thigh like this, a really unusual presentation. The most likely diagnosis in this 30-ish-year-old with fever. Well, what do you see? A large anterior mediastinal mass, and from CT, all of those possibilities, 3 T's and an L, would be possible. Very hot on the PET. When it's that hot on the PET and it's fairly homogeneous on the CT like it is the soft tissue, this is going to be B-cell lymphoma. It's not thyroid tissue. Thymomas and teratomas can be hot on the PET, but they're typically more infiltrating and irregular. Teratoma has fat and calcification, or at least one of them. This is a very nice example of CT-PET correlation in B-cell lymphoma. In this patient with sickle cell disease, the most likely diagnosis is, yes, you can see the sickle cell disease in the patient's lumbar and thoracic spine. There's a hypodense lesion in the right kidney with a thick wall, cystic component, and also what looks like stranding into the perirenal space. Lymphoma can involve the kidney, but this would be a really strange appearance. It could be a cystic renal cell. I can't say it's not. Mess tumor or cystic, but not with this irregular border. It's usually septations and sharper and multiple cysts present. My first thought, again, you would check with the urinalysis, the clinical history, would be this is a renal abscess. Patients with sickle cell disease commonly have renal infection, and if the patients aren't treated correctly or don't follow instructions, they can develop abscesses, and this is a very nice example of a renal abscess. By the way, it was due to E. coli and Proteus. In this painful forearm, the most likely diagnosis is, well, you see a cystic lesion with rim enhancement. The vessels are intact, but is an intramuscular process. It doesn't have the look of a hematoma, and it's not a muscle infarct. So really the only things you could be thinking about are abscess or sarcoma. The way it sits in the muscle, the cystic component, the rim enhancement, this is most consistent with an abscess. Abscesses in muscle are most common in patients with IV drug use. The most likely diagnosis in this case is, well, what do I see? I see that the patient has a pulmonary valve, and I see lobulations on the pulmonary valve. I see what also appears to be infarcts in the patient's lower lung fields. What's going on? Something's going on with the pulmonary valve. Yes, you can say it's a failed valve or it's failing. It surely isn't the normal appearance of a valve, and it's not really an abscess. What you're looking at is vegetations in the pulmonary valve. It's a complication of valve replacement. It's a complication particularly common in patients who don't follow the correct antibiotic course or in patients who are IV drug users. A really very nice example. The most likely diagnosis in this case is Well, what you see here is thickening of the aorta, but especially thickening of the great vessels off the arch, particularly the left subclavian artery. Ehlers-Danlos commonly gives you aneurysms of multiple vessels. Kawasaki's disease gives you a vasculitis, but often with coronary artery aneurysms. IG4 disease usually involves the abdominal aorta or branches. The disease that classically involves the left subclavian artery and the large vessels of the arch, but particularly the left subclavian artery, is Takayasu's aortitis. Just a really nice example. The most likely diagnosis in this case is, well, what do you see? You see a very large mass involving the right kidney, involving the peri and pararenal space. I don't see any other areas of involvement, though there looks like something pushing near the stomach. This could be a clear cell renal cell carcinoma, but it is large. It's necrotic, but usually they're more vascular. This is not going to be a seminoma. This is not the look of a renal abscess. The most likely and correct diagnosis, large mass necrosis, peri and pararenal space involvement, is going to be a lymphoma. And we mentioned before, lymphoma has many variable appearances in the kidney, from solitary nodules to multiple nodules, perirenal space, diffuse infiltration, multi-organ involvement, and again, could be unilateral or bilateral, many different appearances. A really nice case. The most likely diagnosis in this case is, well, when you look carefully, you see what is an exostosis coming off the femur, and then you can see it very nicely as well. There's a couple exostoses in the femur. It's pushing the SFA but not obstructing it. There's no evidence of a sarcomatous change, and you can develop sarcomas in patients who have multiple exostoses. So this is not a healing femur fracture. I don't see an osteosarcoma or chondrosarcoma. What I'm seeing are multiple exostoses, and they are compressing and displacing the vessel. This can lead to vessel erosion and bleeding, but none of that do I see in this case. The most likely diagnosis in this case is, this is a tough case because it's an infiltrating process involving the tail of the pancreas. I don't see a dilated pancreatic duct or much else. Lymphoma of the pancreas is unusual, so I don't like that. Autoimmune pancreatitis, IG4 disease, is a good thought. Infiltration, no dilated duct, can be segmental or diffuse. This is not the look of acute pancreatitis. Pancreatic adenocarcinoma, we like to see a dilated duct, but it can be infiltrating. And again, sometimes autoimmune pancreatitis versus adenocarcinoma can be tricky. You look at IG4, but only half of patients with AIP will have an elevated IG4. This was eventually biopsied and was pancreatic adenocarcinoma. Really nice case. Anyway, I thank you. Those were 10 terrific cases. I hope you like them, and we look forward to seeing you again soon. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.